When I was told that I was assigned to be the last speaker, I wondered about that. I figured half the audience would have gone or be falling asleep, but I was told I'm to be the cleanup speaker and summarize what has been said before and add my own 2 cents to it. And so before I launch into my prepared lecture, I wanted to touch a few points that have preceded me, which I think are worthy of confirmation. First of all, I remember some years ago an advertisement on the radio or television by some merchant that said an informed consumer is our best customer. Well, that may be said here too. An informed consumer is our best patient, and that's why you're here, to become informed consumers. And so this is an educational process. It may be enjoyable, interesting, but it's basically for your education so you can better take care of yourself, because as you heard, you navigate your own course. That's first of all. And some things need to be said over and over again, because education is a repetitious process, so that the important points are said again and again so you remember them. Now, with that being said, there are a couple of points that I wanted to make. We all have heard about the neuroendocrine cell, and you wonder, why is it called neuroendocrine cell? Why isn't it called something else? Well, I'll tell you why, for those who are curious. As you know, neuroendocrine cells produce hormones that travel through the body and bring about a response in cells elsewhere. They're effector cells, and they produce substances that travel, hormones and chemicals that cause these results. But they also have similar features to nerve cells, neural cells, whose job is to carry information, carry a message from one point to another down through the long extensions of the cells, the axons, for example, and so like telegraph wires. And they have in the core, in the nucleus of the cell, little particles which contain certain chemicals, and these particles are also present in neuroendocrine cells. And so they have these neuroendocrine cells, which are sprinkled throughout the body but not all aggregated in one lump, that form an endocrine gland like the adrenal gland or the thyroid gland, etc., nonetheless serves as a glandular system. So this is how the name neuroendocrine cell came about. And we'll probably be discovering more features about these cells as time goes by. Now, totally different. Why do we consider questions of importance about centers of excellence? In Europe, criteria have been established that must be met for a center to be designated as a center of excellence, and they get an official stamp of approval for that, and they have to be examined and reviewed periodically by the European Neuroendocrine Tumor Society, that is the regulatory agency for that. We have no such setup in the United States. We have no qualifying agency, no standards for qualifying any particular group as a center of excellence. We've proposed it, but nobody wants to take up or has in the past taken up the role to be the regulatory agency. Yet places are, both those who really would be qualified and many who not, have assumed the title, and they declare themselves centers of excellence. So this is buyer beware. Keep your eye out to make sure if someplace that is treating you says they're a center of excellence, look into the reason for that declaration, because they may not all be. Now, some other points. The question of why go to a multiple discipline office or center. And as you heard, the complexity of the disease needs the input from very many different specialties. And they're not all often in one spot, but the disease and its treatment has become so complex and involves so many different fields that no one person can know enough to be able to do them all. We need surgeons, we need pathologists, we need oncologists, we need nuclear medicine physicians, we need interventional radiologists, etc., etc. They all have to be in communication and work smoothly like parts of an engine fitting together. And then there has to be somebody who operates that engine, who oversees the whole thing. This is why the days of one doctor taking over the whole care is not anymore existent. All right, also, a word about safety of octreotide or lanreotide as far as that goes. There's very little evidence of any danger of side effects from overdose. It's hard to get an overdose of any of those drugs, so that if there's to be an error, it should be on giving more than is needed, not less than is needed. This is very important because less knowledgeable physicians equate it with giving insulin to a diabetic, where not enough is harmful, you don't get the maximum benefit. If you give too much, you cause other troubles. But that doesn't work that way in carcinoid disease treated, or the other neuroendocrine tumor treated with octreotide or lanreotide. So do not be worried about an overdose. And then finally, the use for depression in patients with drugs called SSRIs, like Zoloft, for example. These drugs are called SSRIs because they're serotonin reuptake inhibitors, and that works fine in the brain, but these drugs have a little bit, a small effect outside the brain. In a patient who doesn't have severe elevated levels of serotonin, the drugs are okay. But if you have a roaring carcinoid syndrome, you cannot take these drugs because they will worsen the case, worsen your symptoms. So this is not very well appreciated in general, but because usually most carcinoid syndrome patients can get away with it. But it is something to be kept in mind if it's a severe syndrome. And finally, a little gem that for those who have the problem of requiring hemodialysis for renal failure. The dialysis gets rid of the blood levels of lanreotide or octreotide. Therefore, if you're on those drugs and you go for dialysis, you'll walk out of that process with normal, that is, lowered blood levels of these substances, and they have to be supported right away with the short-acting injection, and that may have to be done after each time dialysis is carried out, or else you're getting no benefits from or protection from those drugs. All right, with these various comments, now let's proceed. I'm going to present some very briefly, some a little more in detail, advances that impress me as having been of considerable importance in managing or diagnosing this group of diseases, not just over the past 2 years, but over the past 3 or 4 or such years. And this is an outline of what I'm going to cover. First of all, the very basics. Before I go into details, I think that it's important to go over some genetic factors, since we've entered the genomic era of medicine, and I don't think there are too many in this audience who are really schooled in genetics, and that becomes increasingly important because that's where the future of treatment and diagnosis lies. And so I'm going to give you a 101 crash course in genetics. That's first. We're going to talk about the cell. We're going to talk about growth signaling pathways, particularly the Mtor pathway, which you may or may not have heard about. Then in diagnosis, I'm going to review very briefly what's the current situation for the Gallium 68 scan. I'm going to make comment about the NET test, a new test being done by Wren Laboratories that many of you may have heard of. Then there are some newer techniques for diagnosis called the double or single balloon enteroscopy, a means of visualizing the small bowel, the interior, with more detail than can be seen from a standard CAT scan or MRI. And then also I will mention briefly some comments, some features in newly evolving surgical concepts. Then for treatment, I'm going to mention the ProMed study, the Clarinet study, which most have heard of, a few words of about Everolimus and sunitinib, and then other drug combinations, so-called CAPTEM, Everolimus sandostatin, a few words on PRRT, and finally molecular profiling. Much of this you've already heard, and so I'll be very brief, but just give you my thoughts up to date. Here is the cell, a cartoon of the cell. And the important things that you should note is that in the center of the cell is the nucleus. In the nucleus is the chromatin. That's the coiled up strands of the chromosomes that carry the blueprint for the entire genome, the entire structure of that, not only that cell, but of the whole body. Everything is in there. And this is where the headquarters are in each cell for its replication. And outside that, in the cytoplasm, the content of the cell body outside the nucleus, are various structures that have specific purposes. Some are to make proteins, some are to package things that have to be extruded from the cell, either for transmitting messages elsewhere. Granules or vesicles, like they have in nerve cells, are also present. And then there's a cell membrane, that's the coating around the cell, through which all signals to the cell have to pass. And this is important because the receptors you heard about are in the membrane. So given this very simplification, we'll go on a little bit. And here we talk about genes and chromosomes. And you see here a spiral formation with two sides to it. Imagine, if you would, a ladder with two sides and the steps that run across hold the two sides together, and then the whole thing is twisted. That makes a spiral, a double-barreled spiral. That's the helical feature. And if you wish, it's a double-stranded necklace that's twisted, like a cable is formed. And the combinations of the 2 amino acids that make those cross links vary from all sections, and those variations are the sequence of these variations are what are studied in determining the characterization of the genes. And the genes are like the beads that fit on a necklace, only they're part of the necklace. And there may be as many as 500 or 600 different cross links in each gene, or even thousands. And there are actually 23 chromosomes which are paired, so it makes a total of 46. And these are coiled up inside the nucleus to make the chromatin. And one chromosome is no thicker than something like 1/1,000,000th of the thickness of a human hair, but as long as 5 feet long. So it's really a long, thin strand, and it's all compressed in that structure. And here they've actually taken pictures of the different chromosomes. And now, to digress a little further for a moment, there is such thing as a cell cycle. That means the cycle in the life of a cell from when it starts until it dies off, with a rest period that's called cell arrest. And you see here, this is the rest period. During that period, the cell is not growing, it is not vulnerable to chemotherapy, and all of the activities that occur and are related to chemotherapy occur during the active phases. And you can see here, when the cell is replicating, the chromatin, the chromosome, divide and are split into 2, so that the cell divides into a daughter cell which is identical with the one from which it arose. Now, during the cell cycle, mutations can occur. That is to say, some of the genes get a deficiency, an amino acid gets dropped out, or an extra one gets added in, or the positions change. And all of these mutations can lead to changes in the character of the cell. Some the body can repair, and there's a setup for that to be done. Some cannot be repaired, but they're minor and they don't cause any problems. But some mutations are critically important because they change features. Depending on what kind of a cell is involved, it can be anything from a change in the color of your eye, to the size of your arm, to organs, or the lifespan of the cell. The cell does not die off when it's supposed to. Apoptosis is the name given to programmed cell death. Like your cells are not like the bricks of a building. Once they're put in place, they stay forever until the building crumbles. These cells are individually always dying at programmed periods of time and then replaced by normal, similar cells. But if apoptosis gets affected by a mutation, then the cells may not stop their march to senescence, but rather just keep on growing and growing. And that is what cancer is: uncontrolled replication of cells of the type which characterizes that particular cancer. And here, examples of mutations, different change in the colors of the same flower, for example, or change in the color of an animal. These are obvious. And here, how does cancer develop? The normal cell, first mutation, makes only one that's a little bit off, but doesn't do much. but then we see more the second time there's a mutation, and then more, a third mutation, and on until finally we get a malignant cell, and then the cells are so-called off to the races. There's no stopping them. They grow and grow and grow. And here, as I said before, when a mutation cannot be repaired and the abnormal cells continue to multiply and become resistant to death, that is apoptosis, cancer occurs. And now, how do we look at cell growth? Well, you saw this with Dr. Odoricio. He showed you Ki-67 with the staining in the cells that we do and should be doing on every biopsy specimen to tell what the proliferation index is. That is, what percentage of cells will show this Ki-67 or MIBG, either one, which are indications of the actual occurrence of replication in the process or is about to take place. And then on the left side, the mitotic count is how many cells are undergoing replication or mitosis. And you can see the circled points where there's replication in process, because you see the dark colored clumps of chromatin that stands out different from the other cells. And we count what percentage of cells have mitotic figures, and that tells us these two determinations, what the aggressiveness, what the degree of malignancy of the cells are. And we classify them as G1, G2, and G3. G3 would be called a high-grade tumor, much more rapidly growing, resistant usually to ordinary chemotherapy. G2 is intermediate, and G1 is very indolent, slow-growing. Now, a word about genetic familial syndromes, which was touched upon before. For carcinoids, there are 4 different types of disease that are associated with genetic transmission or inherited carcinoids. These 4, though, usually are associated with either foregut, that is lung carcinoids, or pancreatic carcinoids, not with the midgut or small bowel carcinoids. Those are the MEN, multiple endocrine neoplasia type 1, Van Hippel-Lindau syndrome, which is very rare, and neurofibromatosis 1, and finally tuberous sclerosis. These are all very rare syndromes, but they are familial in their transmission and in their association with neuroendocrine tumors of the type I described. I will comment further on familial carcinoid, and that refers to midgut carcinoid, which very recently has been given some proof as existing, and which Nancy commented on, and in the July issue of the journal Gastroenterology, the people from the National Cancer Institute at NIH reported on a long study they've been doing on a series of patients, which they proved a specific genetic mutation that runs in families for the occurrence of midgut carcinoid. This has, it's still a study in progress, but it could have very important implications, since other members of midgut carcinoid patients might be at risk and not know it. Now, this very busy, complex slide is not shown for you to really read, but just to show you the complexity. At the top of the slide, you see a representation of the cell membrane, and you see a number of receptors which are activated by a variety of stimulus that can come there. This whole complicated slide shows the Mtor pathway, and that is a pathway that stimulates growth or replication of the cells. And when these receptors are activated, then through various channels, you see the arrows and courses indicated, it goes down to the nucleus and triggers off replication of the cell. This is only the mTOR pathway. There are literally hundreds of other growth pathways, some triggered in different mechanisms. Many are triggered by a tyrosine kinase G protein on the surface, which is activated by various mechanisms, and which the new targeted tyrosine kinase inhibitor drugs inhibit. And so this is the mechanism whereby some of our newer drugs will inhibit the cell division and thus act effectively in inhibiting growth of the neuroendocrine tumor. And more about this in a minute when I talk about new drugs. And here if for those who don't know it, is a representation of the Gallium Scan, this newer scan, which will very soon be available for general use in the United States, is much more sensitive than the Octreotide scan. On the left, you see the Octreotide scan, and you see some faint positive indications. Here's one, here's one. This in dark thing is the liver, and there are nodules represented there. Here's one in the hip of this person. This is in the urinary bladder because the isotope is excreted that way. And so that we know there's some spread. But doing the same case with the Gallium scan, look at how many more hotspots there are. They're almost countless. These are all lesions that were not seen on the Octreotide scan. They may be very small, but there's certainly more. So this new scan can be very helpful in differentiating what's operable, what's not operable, and help in decisions of treatment. And also, as you heard, can help indicate the vulnerability of the tumor to PRRT treatment. So this will be available. It's not exactly clear yet, but perhaps within a year in this country, and then will no longer be experimental, but would be covered by the usual insurances. Now, a whole different approach. We often think that there's a primary tumor in the middle of the small intestine, too small to be seen by the ordinary small bowel X-ray study, and not seen by the wireless capsule, which are the so-called pill camera. And so what can we do to find it? Well, it may be too small or have too few receptors to show up on Octreotide scan or even Gallium scan. We now have a system of an endoscope with either 2 balloons or 1 balloon on it to make the double balloon or the single balloon endoscopy available. These long scopes can be passed through the mouth down into the upper half of the small intestine or through the rectum, like a colonoscope, up into the more distal parts of the intestine. And between the two approaches, we can see, usually, not always, but usually, the entire intestine. And unlike the wireless capsule, biopsy can be taken through this device too. And the way it works is the instrument is passed as far as can go without the balloons being inflated. Then they're inflated one at a time. The inflation holds the thing steady in the intestine while the rest of the tube is pushed further. Then the first balloon is decompressed, allowing the elasticity of the bowel to let the rest of the scope slide through like a telescope that opens, and then the second balloon can be inflated to hold it there. And so push and pull, push and inflate and deflate is done repetitively, and the whole thing is advanced. It takes a long time, a couple of hours, to do it all, and there are not many doctors that are experts at this field yet, but it's coming, and it is a way that we can learn, or we can discover suspected primaries in the small bowel. And here's a picture just representing the way it would be for a lesion in the small bowel with the colonoscopic introduction. And here is another picture of the single balloon, where it would be passed, the balloon and inflated, the thing would be pushed forward, and there's a sheath, and in it is an inner tube, and that gets advanced. And so push, pull, inflate, deflate, and so forth advances the tube. And here's what we can see. Here's a carcinoid way up in the middle of the small intestine that is seen through one of these devices, which went undetected by the usual diagnostic methods. Now, on a totally different issue, the NET test, which is done by Wren Laboratories, which purports to diagnose the presence and severity of any type of neuroendocrine tumor using a genomic technique called PCR, and it measures the quantity of 51 different gene fragments, transcripts, of neuroendocrine tumors in the blood. The idea is that, like a tree that sheds leaves and they get blown around in the wind, and then you pick up the leaves and can, at some distant spot, and can tell what kind of a tree it is, and or how many trees by the number of leaves that you find. And so this is the proposed, in very simplistic terms, what this test does. It's still experimental, it's not proven yet, and it doesn't give a yes or no answer, it gives a probability answer, so that I can't endorse it, nor can I refute it. I can just say it's not the gospel yet. Now we come back to this new familial carcinoid. There have been the clinical observations. I've seen a number of such cases, and Nancy said she had seen some too, and I'm sure that anybody who deals with the carcinoids to great numbers will have seen one or two at least. There are clusters of small bowel carcinoids where several members of the same family will have carcinoids, or maybe in the family background, a grandfather or an uncle, etc. The NIH Cancer Center, the National Cancer Institute, studied 33 families in which each family had at least 2 cases. And they screened undiagnosed asymptomatic relatives of these cases too. And they found sporadic small intestinal carcinoids to be indistinguishable from, in this group of patients, from the regular carcinoids. In other words, they were the same type of tumors. There was nothing else different, whether they were apparently familial or so-called sporadic. But very interesting is that 34% of the symptom-free relatives of those who had the, what appeared to be familial, the symptom-free relatives over age 50, 1/3 were found to have occult carcinoid tumors. They underwent surgery and were cured in each instance. So they found a number of people related to those who had carcinoid that had these latent, obscure lesions, unrecognized and no symptoms, and therefore never had any workup to look for them, that did indeed have carcinoid, and so they could be successfully found and operated. This is still experimental and unproven yet, but it looks good. And the message, the take-home message is, if you have more than one person in your bloodline that has carcinoid, the other relatives should at least have investigation to see if they have unrecognized carcinoid. Now, to go one step further, they found out what the genetic trouble was. There was a mutation in a gene called inositol polyphosphate multikinase, abbreviated as IPMK, and that was present in all the familial carcinoid patients, and of the asymptomatic family members, that there's not the ones with carcinoid necessarily, but in 17 of 35 asymptomatic family members, this mutation was also present. And the suggestion would be that if a person has that mutation, then they are susceptible to developing carcinoid. That hasn't been followed up on yet. This is all a very new finding, but it's very exciting because we may have a new, predictable means of telling who's at risk for carcinoid. It was found that this mutation, how it works, is that it inhibits apoptosis. In other words, it prevents normal cell death. And this is the really speculative part. These researchers speculate that this gene defect might account for between 12 and 35% of cases hitherto considered to be sporadic. That's overwhelming if that's the case, because it means that as much as 1/3 of all the so-called non-familial carcinoid patients have a genetic defect that could be measured. And if that's so, it might become a test that would be more commonly employed in routine screening. Well, stay tuned. We'll see what develops in this. But at least it's a real step forward. Now, some other things that are new, that are not so new, but for those who are here and who don't know about it, I included them. The PROMID study, which is an eponym, as you see here, for a placebo-controlled, double-blinded, prospective, randomized study on the effect of Octreotide LAR in the control of tumor growth in patients with metastatic neuroendocrine midgut tumors, abbreviated as PROMID. That demonstrated a benefit in time to progression for the tumor. In other words, treatment with Octreotide, as you heard from Dr. Odoricio, prolonged survival time, prolonged the time between tumor progression. This was reported, this study, in 2009, and led to the use of the drug for inhibiting tumor progression. Similarly, the CLARINET study, which stands for Controlled Study of Lanreotide Anti-Proliferative Response in Neuroendocrine Tumors, demonstrated a similar benefit in progression-free survival, PFS, for patients with both pancreatic NETs and extrapancreatic NETs, in other words, small bowel tumors also, as well as lung tumors. And very important, that hasn't been emphasized, this effect of inhibiting tumor growth was not dependent upon a positive Octreo scan. It was equally present in both positive and negative Octreo scan patients. So it's not dependent upon that receptor. This too has eventually led to the acceptance by the FDA of this drug. This would be lanreotide or somatulene, which was approved only this past year for general use in the United States. Now, another drug that's been in use longer and has been approved for peanuts, but has now been shown to be also effective in midgut and lung carcinoids, is Everolimus, which you know as by the trade name of Afinitor, and that's an inhibitor of Mtor. Mtor means mammalian target of rapamycin, which is kind of a mouthful, but it just simply describes what it is. Rapamycin is derivative from the island where, Easter Islands, where this was known as Rapa Nui, and so they found this original material there. Anyway, it's called Mtor. The FDA approved this for pancreatic neuroendocrine tumors in 2014, and it's usually used in conjunction with octreotide, which seems to enhance its efficacy, as it seems to do for many other forms of chemotherapy. And this, as I said, is also effective for midgut neuroendocrine tumors, but not yet formally approved for that use by the FDA. Sunitinib inhibits tyrosine kinase VEGF, vascular endothelial growth factor pathway, and the FDA approved this for pancreatic neuroendocrine tumors in 2011. It also is often used with octreotide, or now lanreotide. Again, a few words about PRRT. I won't dwell on this since you heard about it. It was known as, in the United States, as the NETTER-1 study, and it used lutetium-177 dotatate, and the patients treated with this were compared with those treated with long-acting sandostatin alone, and had a very favorable outcome. And this was used for advanced small bowel carcinoids. It was sufficiently successful that the FDA has given it a fast track for reviewing, and the company who sponsored this thinks that it'll be approved within this year. That would be wonderful, because many in this audience have gone to Europe, and a few perhaps to Canada, for their PRRT treatment, and if once it's approved, it'll be available for general use in the United States, and the insurances will cover it. So again, stay tuned. Now, I want to comment on the recognition of increased efficiency of drug combinations. For example, octreotide and alpha interferon have been known about for many decades and have been used for a long time. We haven't relied upon it very much lately because we have many other drugs, but it's still occasionally used and can be an effective alternate. Capecitabine and temozolomide, so-called CAPTEM, has been recognized, and for both pancreatic and for midgut carcinoids. Folfox, leucovorin 5-FU oxaliplatin, also useful for midgut carcinoids sometimes. And of course, as I said before, octreotide and everolimus in combination seem to have better effect than either drug alone. And now finally, a rather neglected area: how do we treat small cell lung carcinoid or lung cancer? How do we treat G3 that is the highly active neuroendocrine tumor, the ones with a MIB1 or Ki67 incidence of over 20%, and sometimes it approaches as high as 100% in these very aggressive, rapidly evolving tumors. Until now, the only treatment that was really effective and that's still used is a platinum-based, cisplatin or carboplatin with etoposide, which works in about 2/3 of the cases, but only for a number of months. It's temporary and has potent side effects. Now, in a similar group, sunitinib was tried in a double-blinded clinical trial involving 144 patients. 78 were treated with the active drug, and 34, that's roughly a half, had a beneficial response, either a complete response or partial response or just stable disease. This was carried on at Duke University School of Medicine. Eric Baudin in France did a similar study on a much smaller number of patients using just Folfox as a second line of treatment, and he noticed again a favorable response in a significant number of cases. These are not world-shaking studies, but they do open the door for something else that you can do for a hitherto pretty much recalcitrant disease that had nowhere to be approached after the platinum regimen was over. Finally, a comment about molecular profiling, which did not enjoy a good reputation until recently. This is analysis of the tumor tissue for its molecular content. Just like all of us have the same anatomy in all respects, with one exception, we each have a unique fingerprint. That no two people have the same fingerprint. And similarly, the same tumor in multiple people will have the same chemistry, the same molecular profile, except there'll be a little bit of difference that's unique to that particular tumor. And sometimes that molecular composition allows a vulnerability to one or another of the drugs that we can use, that we have now that we have a larger armamentarium to draw upon. And so this, using genomic and immunohistochemical techniques, we can determine what the unique chemical signature is of these tumors, and that is an assistance in choosing what drug to treat. In fact, I try to do this test on most of my patients now. It's very expensive, but most insurances will cover it, and it can be done on preserved tissue. Doesn't have to be fresh tissue. There are a number of purported molecular profile techniques at different hospitals and different centers. They don't do everything. They don't do a complete job. There are only a few laboratories really specializing in this that will do the best job, and so this is very important to know where it's being done. Also, there are many oncologists who don't really feel comfortable with depending upon these results, since as recently as a decade ago, the use of molecular profiling for ordinary cancers was very inaccurate and very unsuccessful in predicting what would be effective treatment. So that general impression has been carried over for neuroendocrine tumors, which does not pertain actually. When we've reviewed a large number of such cases, and I've done over 200 now, there's about a 75% correlation between what the molecular profile suggested as a good drug and what the actual clinical response was to treatment with such a drug. So it's a helpful technique for neuroendocrine tumors in aiding decision for what you're going to do. And in recognition of the growing importance of molecular profiling, ASCO, the American Society of Clinical Oncology, has just initiated a nationwide study, TAPOR, abbreviated for Target Agent and Proliferation Utilization Registry, where they're seeking oncologists throughout the country to do molecular profiling so that they can get a vast number for all different tumors, to a vast number of cases, to help decide on the value of this. But it looks important enough to them to warrant the involvement in such an extensive study. So finally, in conclusion, in the last 5 years, there has been more production of diagnostic and treatment modalities than there were in the preceding 2 decades. The future is increasingly promising for the carcinoid and neuroendocrine tumor. Thank you.